co-speakers, Dr. Henry, Dr. Poggio, the organizers of this prevention summit, and myself. Really would like to thank you for taking time today to join us, and I would like to welcome you to our webinar entitled The Rising Challenges of Non-AIDS Defining Cancers in People Living with HIV, a Growing Nemesis. The reason we picked this topic, it's because non-AIDS defining cancers really have become a significant cause of morbidity and mortality among people living with HIV. As a matter of fact, they are the second cause of death among our patients. And it is extremely important to bring this back on the radar screen of both our patients and providers. With that said, the purpose of our webinar today is to define the scope of this problem, as Kyle alluded to, and more importantly, what we would like to do through a case presentation is to share with you the best ways to prevent and screen for these cancers so we can really impact the morbidity and the mortality associated with these cancers. And finally, we're going to open it for Q&A. There is no question, I would say it's unequivocal, that the rate of non-AIDS defining malignancies has significantly increased during the last 10 years. And as I mentioned to you, it is the second cause of death among people living with HIV in developed countries. And that's exactly why, despite the advent of absolutely incredible antiretroviral treatment and combination of antiretroviral treatment that really extended the life expectancy of our patients significantly, the life expectancy of our patient hasn't quite normalized. And the reason being is because cardiovascular disease, number one, and cancers, non-AIDS defining malignancies, number two, really are more prevalent among people living with HIV, and they are associated with higher mortality. They are deadlier than people who are not living with HIV. So what are these non-AIDS associated malignancies? As you know, people living with HIV can develop two types of cancers. You have those that are AIDS associated malignancies that occur really with advanced HIV disease, end stage, with very weakened immune system, low CD4 counts, and these are Kaposi sarcoma, invasive cervical cancer, non-Hodgkin lymphomas that we're not going to address today. Thankfully, those have dropped too low on our radar screen. On the other hand, the non-AIDS associated malignancies that we're going to focus on today are the lung cancer, the colon cancer, the anal cancer, the liver cancer, Hodgkin lymphoma, the oropharyngeal cancer, laryngeal cancer, and skin carcinoma. These are the ones that have emerged to be a real nuisance and a real problem for our patients and for us as clinicians. Now, as you know, the best way to deal with cancers is to prevent them from happening in the first place. Prevention is key. And as you know, a good chunk of cancers are preventable. If we take certain measures, which we're going to discuss throughout our presentation today, we can really decrease the chance of these cancers from happening, as such as no smoking policy. No smoking is critical. Treating HIV is very important. Avoiding prolonged sun exposure, healthy diet, and more importantly, certain vaccinations that are key to prevent the emergence of cancers. So prevention is key. And then really the second best thing that we can do when it comes to cancer is, if we cannot prevent them, is to detect them at very early stages, i.e. in their precancerous stage or at the very early stages, so we can intervene and prevent them from becoming disseminated and from becoming non-curable and eventually becoming extremely harmful to our patients. So this is what screening is all about, is early detection that allows us to intervene and prevent things from becoming a serious issue. And unfortunately, sometimes we can't prevent nor screen these cancers, and patient will present with their first manifestation being a full-blown cancer. In these settings, the best thing we have is treatment. And we're going to use every modality of treatment to aggressively treat and control and eventually eradicate cancers. And those could be surgery, chemotherapy, it could be radiation therapy, immunotherapy. What we're going to focus on today primarily are prevention and screening. This is a very important slide. And the reason being is it really compares the rates and specifically the incident rates of non-AIDS defining malignancies in people living with HIV compared to the general population. And what I really want you to take note of is that when you look at anal carcinoma, it's 78 to 1. It's way more prevalent among people living with HIV, specifically MSM. Hodgkin lymphoma, 64 to 3 ratio. Liver cancer, lung cancer, melanoma, oropharyngeal cancer, and colorectal cancer, they're all more prevalent and very likely deadlier among people living with HIV compared to non-HIV. I want to point out that breast and prostate are not much different between HIV and non-HIV, and that's why we are not going to discuss or address in today's webinar. So the big question is, why people living with HIV have such a high incidence of non-AIDS cancers? Well, we have good reasons as to why this is the case. The first and most important one is people are victims of their own success. In fact, the advent of antiretroviral therapy enabled us to prolong the life expectancy of our patient, and as such, they are aging. Our patients are aging. Age is a very important risk factor for cancers, as you know. And not only this, as they are living longer, we're extending their exposure to carcinogens such as smoking, and more importantly, to oncogenic viruses. And what oncogenic viruses are, these are like hepatitis B virus, HPV virus, and even HIV itself. These are viruses that can facilitate and trigger the birth of cancer cells over time. So by prolonging the exposure to these viruses, we're increasing the risk of cancers downstream. Both carcinogens and oncogenic viruses tend to cluster among people living with HIV. So these are very important reasons. The second important reason is the chronic inflammation that's associated with HIV. As you know, despite full viral suppression, people living with HIV tend to have an ongoing state of inflammation that can be measured by measuring inflammatory mediators. This inflammation really creates a favorable environment for cancer cells to emerge in certain tissue. And not only this, this inflammation can tinker with the tissue and damage certain tissue, increasing the risk of cancer emergence. So that's very important to keep in mind. And finally, and probably one of the most important reasons why cancers are more prevalent among people living with HIV is the next state of immunosuppression that people have, people living with HIV tend to have. The immune system is the most important system that they have to keep cancer cells under check. It's very important. And when then, even though with HIV therapy, people tend to have a slight net level of immunosuppression despite full recovery of their CD4, and that really can contribute to the genesis of cancers. So these are the reasons when you kind of like the interplay of all these factors that leads to the higher incidence and prevalence of both AIDS and non-AIDS cancers among people living with HIV. As I mentioned to you, certain viruses play a significant role in the genesis of cancer. These are the oncogenic viruses. And this table shows the malignancies that are related to these viruses. Hodgkin and non-Hodgkin lymphoma associated with EBV that Dr. Henry will address later. Hepatocellular carcinoma associated with hepatitis B and also with hepatitis C when hep C is causing significant damage and fibrosis to the liver or cirrhosis. Kaposi sarcoma of HIV A, and most importantly, anal, cervical, vulvar, vaginal, penile, stomach, and oral cancers that can be associated with HPV virus. I want to point out here that if we vaccinate people for hep B and HPV, we can prevent a lot of these cancers, as you can see. And if we can treat and cure people from their hep C, we can literally minimize drastically the risk of developing liver cancer. And then you have those cancers that are unrelated to infections, like lung cancer, prostate cancer, colorectal cancer, and breast cancer that are, so far, we have no evidence to link them to any viral oncogenes or viral infections. The START study is of paramount importance, and what the study consists of is, this is a study that targeted people living with HIV who were naive to treatment and randomized them to immediate or early initiation of antiretroviral therapy at the CD4 above 500 or deferred antiretroviral therapy until the CD4 dropped below 350. And as you can see, the rate of comorbidities and mortality was significantly higher among patients who deferred antiretroviral therapy versus those who started immediate antiretroviral therapy, underscoring the importance of the immune system and underscoring the importance of early initiation so we can preserve that immune system. And what you can see on the left-hand side of the slide are the different kind of cancers that were seen in the study. Bear in mind, the study was discontinued by the Daily Safety Monitoring Board because of the high rate of complication encountered among people who deferred antiretroviral therapy. But again, people who deferred antiretroviral therapy had almost 2.5 higher chance of developing a cancer down the road than those who started early on. So this is very important to keep in mind. Another slide that underscores the importance of the immune system in preventing the genesis of cancers is this one. And what you're looking at here is data showing an important correlation between the current CD4 count and non-AIDS complication across the board, renal, cardiovascular disease, and liver, but more importantly, non-AIDS malignancies. The higher the CD4 count of our patient, the lower the likelihood of them coming down with cancers downstream. And this is exactly why we strive as clinicians and we continue to push for higher CD4s in our patients when we are treating them. So this is very important to keep in mind. And with that, what I'd like to do is I would like to really pass on the baton to Dr. Juan Poggio, and who's going to start the case presentation. Thank you.
Okay, thank you, Dr. Munther. Thank you, Kyle, and it's a pleasure to be here with Dr. Henry too. Good morning, everybody. So we're going to start with the case presentation, and this is a patient that presents to us with a history of anal warts in the past. He's 51 years old. He has a history of receptive anal intercourse, very compliant with medical therapy for HIV disease, no baseline resistance, no history of treatment failure, adequate CD4 counts more than 400, viral load less than 20 copies per milliliter, a history of hypertension. He doesn't smoke, a recent history of sexually transmitted disease with gonorrhea that was treated, and his chief complaint is mild anal irritation. So the question is, what is our approach to reduce the morbidity and mortality related to cancers in this patient? And I will proceed to start with colon cancer. Here in this graph, in these pictures, you can see the development of colon cancer inside the lumen of the colon on the left, and different stages of spread or disease. And then on the right, you can see a picture of a polyp that over time became a cancer of the colon. In the next slide, what I wanted to let you know is why we're talking about colon cancer. Well, it is the second leading cancer killer in the United States, and it affects both men and women. Of course, the risk increases with age, and some patients are at increased risk if they have a family history. The good news about this is that while it is a very important cancer and the prevalence is important, the good news is that it's preventable, and if detected early, it can be curable. So that's where we're going to concentrate. There are different societies. The USPSTF, it's a society, a national society of experts that recommend that we start screening for colorectal cancer at the age of 50, and we continue until the age of 75. And we are going to describe different screening modalities. But also I wanted to add that in 2018, the American Society of Colorectal Surgeons, which I belong to, changed the recommendations to start screening for colon cancer at the age of 45 because of the increased risk of colon cancer found in younger patients. So here I put that if we talk about screening modalities, the preferred choice is colonoscopy. Personally, it is my preferred choice, and I will explain you later, but there are alternative choices to look for early colon cancer or precancerous lesions. Alternative choices for screening for colon cancer, not for polyps, is the Cologuard test that has been very popular in the last years. The annual FIT, we can also look for fecal or cut blood test. And if not, we can also use do a flexible sigmoidoscopy every 5 years, alternating with the fecal or cut blood test. There's also the mentioning of virtual colonoscopy or CT colonography that nowadays is used only in very specific indications that I don't think it's pertinent to this discussion today. Next graphic, okay, so why do we say it is preventable? Well, in most patients that doesn't have any family history, it is preventable because we can look for polyps. Here in the pictures, you can see polyps in the left, in the center, and through the colonoscopy, we can find these polyps and remove them before they become cancerous. And if they have cancer, we are removing them at an early stage, where the survival of that patient having this diagnosis will be much higher or better. And that's why it's important to remember that we can prevent colon cancer in most patients by doing this screening study or diagnostic study. Next graphic. Also, not only screening is very important. When we talk about prevention, like Dr. Mansur was mentioning, it's important to also look at our lifestyles. You know, a low-fat diet is important, increase in vegetable and fruit intake, high-fiber diet, regular exercise that it has been shown not only to decrease the incidence of colon cancer, but other cancers. And importantly, there's a lot of studies that shows that smoking affects patients and is involved with increased risk for colon cancer and other cancers. So before we go into this, Dr. Mansur, in conclusion, with colon cancer, it's very important to know that you know, it is preventable. It can be done with a procedure called colonoscopy. There are other alternatives, but the colonoscopy, it is my opinion, that is the only procedure that can diagnose and treat and remove these precancerous polyps before they become cancer. All the other tests are not, they don't provide this option. Thank you, Dr. Mansur. So now we're going to go to talk about anal cancer. As we mentioned before, anal cancer is prevalent in the HIV community, and while it is uncommon in the general population, it has been raising, the incidence has been raising in the last several decades in men and women living with HIV disease and in some subgroups. What we have noticed is that patients, men having sex with men and immunocompromised patients, the incidence has been increasing dramatically over the last years, and that's where we have to be vigilant and working on prevention strategies and treatment strategies. Next slide. So when we talk about anal cancer, what we are finding is that there are some markers or lesions that we believe are, if over time, can lead to cancer, like anal warts or anal dysplasia. While the risk of becoming cancer is very low, we need to know that it is present. And here's where the mentioning of human papillomavirus infection is important, because what we found with anal cancer is that 91% of anal cancer has HPV infection, and the HPV, human papillomavirus, is involved with the development of this cancer. And within the HPV subtypes, the 16 is the most common type found in individuals or patients with or without HIV. So when we talk about prevention, what have been very important over the last years is the vaccination for human papillomavirus. And most of us have heard about the 9-valent HPV that is given in individuals between 9 to 26 years of age with HIV disease. And also there is a discussion that has to be done in patients that are older than 27 years old and less than 45 of age, whether HPV vaccination is going to provide some protection. So this is extremely important to know for providers and for the patients to discuss with the providers. cervical anal pap smear has become a modality for screening for anal cancer. Here in this graphic, you can see cells that are affected with human papillomavirus. And on the left of the graph, you can see that these cells have some changes. We call that low-grade squamous intraepithelial lesions, or low-grade to mild dysplasia. But when we go to the right, over time, or depending on the HPV type, these cells can become more aggressive and eventually become very, very aggressive, multiply, and increase the risk of developing to anal cancer. And this is what the anal pap smear detects. So this is a very important guideline for detection and prevention of anal cancer. There are several guidelines, but we thought that this is important to review with the audience today. First of all, at baseline and annually in patients living with HIV disease, regardless of age, clinicians, primary care doctors, HIV doctors should inquire about any anal symptoms like itching, pain, discomfort, lumps or bumps. We should perform an annual anal exam, visual examination of the anal area, perianal area, and then do a digital rectal examination that can diagnose anal cancer just by that examination. And then also annually, what we are doing in most of the offices is doing an anal cytology or anal pap smear, especially annually, and with men having sex with men, or any patients with a history of condylomas or warts or dysplasia, and also women who have cervical dysplasia or a history of vulvar dysplasia. Smoking cessation is very important for all patients with HIV, but also we found that it's extremely important to discuss this in patients living with HIV who are at an increased risk for anal cancer. So also, as I mentioned before, any patient more than 35 years old living with HIV disease should have by their clinicians a digital rectal examination annually to screen for anal pathology. And also any patient who have any anal symptoms should be examined. This is extremely important, and we recommend to do this annually. Here, what you can see is that when we do anal pap smear in the office, the anal pap smear can tell us whether there are some precancerous lesions or not. They don't say whether there is cancer or not, but that allows us to go ahead. If there's an abnormal pap smear that shows that cells are not behaving normally, then we can do in the office or in the operation room what we call a high resolution anoscopy. In this picture, you can see like a microscope here that amplifies the anal lesions. On the right, you can see a precancerous lesion. And this high-resolution anoscopy nowadays has become the standard of care for most societies, where we can look for these precancerous lesions, biopsy them, and sometimes, if needed, we can treat them with excision or distraction. And that's what we are looking at. We are looking at annual examinations, anal pap smears every year, and if it is abnormal, they can be referred to a colorectal surgeon or an HIV specialist to perform a high-resolution anoscopy exam. So in conclusions, HPV infection or human papillomavirus infection is associated with the development of anal cancer in more than 90% of cases. Different degrees of dysplasia can progress to cancer or not. We don't want to be alarmist, but we know that over time, over years, some of these lesions may progress to cancer. We're still in the stages finding which ones and how much time. The rate is low, but what we know is that the incidence of cancer is increasing. So what we can do is we do the anal exam every year, we do the anal pap smear, and if the anal pap smear shows abnormalities, we should probably refer the patient to a colorectal surgeon or a specialist with high-resolution anoscopy to do biopsies and destroy any lesions that may progress to anal cancer. If there is the diagnosis of anal cancer is made, nowadays the survival is very good and the prognosis is good if it is diagnosed early. That's what Dr. Mauser was saying before. Early diagnosis. All these treatments and examinations, screening modalities allow us to diagnose if it happens anal cancer at an early stage, so the survival is much better for those patients affected by this disease. And then there's a need, as Dr. Manser saying, to restore the immune function and make sure the CD4 counts are more than 400, and remembering the vaccination for human papillomavirus infection. Thank you, Dr. Manser and Dr. Henry. This was my part here.
Thank you, Dr. Pollo. And Dr. Henry, you're next with some of the exciting cases to come.
I'm next. Thank you very much. Good morning, everyone. I got my microphone attached here in this amazing new format on this world. So welcome, everyone, and we'll see what happens in a year if we're still doing this, or hopefully not, we get to see each other. So I'm going to continue, and thanking Dr. Manser and Poggio and Kyle for inviting me, continue with our case-based format. So here's case number 2, heavy smoker, and you'll hear all this morning, smoking is associated with increased incidence and prevalence of these cancers, so try not to do that. So here's a 56-year-old man, HIV. His virus is suppressed. Here's his antiretroviral regimen. He's a smoker, 45-pack here, occasional crack use. He's otherwise healthy, family history unremarkable. Based on these factors, what should we be concerned about? So let's take a look. Lung cancer, as you've seen in a couple slides early on with Dr. Manser, is really prevalent in the non-ACE defining cancer category in our patients with HIV. And as in HIV negative patients, cigarette smoking is the key. We've known that for years. The incidence of lung cancer in our HIV infected patients, 2 to 4 times higher. It may be the biggest cancer in our NADMs, the non-ACE defining malignancy, just by numbers. The risk among HIV infected patients is higher for women. We see that also in the non-HIV category, and it occurs younger, as I'll show you in a slide coming up, which is curious but happens, and in our IV drug users. So it's usually in our final bullet, it's usually diagnosed earlier. So this is a study comparing, you look at the middle column here, the SEER, a large database, 169,000 people. When does lung cancer occur? What age? Median of 68. And here's a study, smaller, but I think it came out of Atlanta a few years ago. And notice the lung cancer diagnosis occurs 10 plus years earlier. So this is really striking and needs us to be aware and vigilant for patients younger than we ordinarily think. So based on lung cancer study group recommendations, how should we screen this patient for lung cancer? So here's a number of things that have been tried, and we'll bring it on home to what we think might work. So should we get an X-ray? So the previous slide, thank you. If we get X-ray, I'll just run through these. X-ray every year. Insurance probably won't pay for that. X-ray every other year. Low-dose CT scan every year. Low-dose CT scan every other year. These are usually low-dose non-contrast. This patient is not indicated, so E choice is not indicated for lung cancer screening. Unclear because not studied in HIV patients. Unsure. Next slide. All right, so screening tests, and you'll hear this theme a lot this morning. For the screening test first should detect a cancer at an earlier stage if it was detected as a result of symptoms. But more importantly is number 2, evidence must support the treatment given at an earlier stage results in improved outcomes. So to amplify that, what if someone is going to live until 2025 die from their cancer? And if you diagnose it in 2018 and they still live to 2025, all you've done is tell them their cancer earlier and haven't had a change in outcome. So we want to catch it in 2018, and it has an impact. The patient will live beyond what would have happened, let's say 2025. Next slide. So you have to weigh the risks versus benefits of screening. What about screening tests? Well, you certainly don't want to screen people and tell them they have something when it's a false positive. So that test should be low on the false positives. We can cause emotional anxiety, of course, because do you have it or not? And if we chase down every possible lead, we're going to start doing a lot of biopsies and invasive procedures and may not be necessary. Next slide. So here is a very busy slide, but I'll give you the take-home points. This was a large, notice on the right top, 53,000 patients. You see at the bottom who they were. This was a study, this is now non-HIV, 55 to 80 years old, 30-pack year history, and they've been smoking or haven't quit at least in the past 15 years. This was the, quote, high-risk group. And so for 3 years, they did annual chest X-ray or low-dose, non-contrast, parenchymal showing CT scans. So in the top curve, you see that the cumulative number of lung cancers picked up was higher, the blue line, with this strategy the low-dose CT scan versus chest X-ray. And of course, the flip is at the bottom graphic. You see that the people dying of lung cancer is worse with the chest X-ray because we didn't catch them early enough, make a difference, get it out, than the low-dose CAT scan. Next slide. So here's another smaller study, but this is in HIV patients where we're still a little not sure, but we think it's got a good idea. So here was a 442 patients, HIV smokers, similar to the study of that large 53,000 database we just saw. And this is in HIV people. Here you see age 40 and older and their helper counts. 9 detected cancers, median follow-up 24 months, median age. But I think the take home here is that 6 of 9 lung cancers were detected by that CT SCAT scan, low res, non-contrast, and that detected early enough to make a difference. So this is a developing database, but certainly a lot of foundation of this kind of approach to given our patients with smokers HIV positive. Next slide. And here's a graphic to show you what it looks like. If you're not familiar with CAT scans, you're being sliced. And so the patient is lying on his back. Here's his spine. Here's his chest. And his head's on the other side of your screen. His feet are sticking out at you. And the black is lungs and air. Here's the trachea, air, black in the trachea. And this thing shouldn't be there. That's a lung cancer. And if you look down the bronchoscope, right here, you bump into that lesion, which is what you're seeing over here. And that's the lung cancer. Next slide. So this lung cancer study group believe this is a great tool for finding lung cancers. The updated guidelines are shown here, and they don't include, this is again something in progress to see really how it applies to our HIV patients, but we believe it's a good idea and a good strategy and probably covered by insurance to screen such patients. Again, the database was 55 and older, 30-pack year history, smokers, annual, low resolution, non-contrast CT scan. Next slide. And gosh, what should we avoid? Tobacco, easier said than done. Compared to non-smokers, men who smoke 23 times more likely to develop lung cancer, women 13 times. We believe smoking is associated with 90% of our lung cancer deaths in men, 80% in women. Remember, women have this curious adenocarcinoma type lung cancer, which may be associated without smoking. They do this more than men. As an aside here, we're checking now for markers in our lung cancers because sometimes they'll have a marker, a so-called backdoor weakness of the lung cancer that a pill can treat them if they're advanced stage as opposed to chemotherapy. And then smoking is associated with, look at this list, larynx, oral, esophagus, bladder. Virtually everything can be worsened by smoking. All right, so let's leave that lung cancer and go on to liver. So our next case, a patient with chronic hepatitis B and or fatty liver. 53-year-old man, MSM phenotype, diagnosed 15 years ago, and is on antiretroviral therapy. No resistance, it was HIV, no history of treatment failure. CD4 is good, viral load undetectable. His hepatitis B antigen is positive, hepatitis C antibody negative. He has a viral load of hep B low, undetectable, and his SGOT, SGPT may be mildly elevated. Hypertension, overweight, this can cause the fatty liver. And based on these risk factors, are we worried about something like liver cancer? And so hepatitis C, hepatoma or hepatocellular carcinoma, strongly associated with viruses. I think of this as like the liver is smoking. So if you smoke and irritate your lung and you get lung cancer, well, if a virus is chronically in your liver, it's irritating your liver and it can become a cancer. Of course, alcohol, heavy alcohol, not a good idea. Overweight leads to the fatty liver, which also can promote liver changes, cancer. Type 2 diabetes, this again is the overweight associated type. And smoking, aflatoxin foods, small but definite cause of problems, or of course infections with other things. Next slide. So what about liver cancer in our patients? HIV infected are greater risk of acquiring and dying of hepatocellular HCC, sometimes 3 to 6-fold excess. Most patients with HIV hep C develop HCC are likely to have cirrhosis in the background. Hepatitis B patients can get HCC without having cirrhosis. And HIV infected patients with getting HCC tend to manifest aggressive infiltrative tumors. Again, as a medical oncologist, I see this when patients are advanced, and we have actually many therapies now for the advanced case, which of course is incurable, but we can make you live longer, but we'd rather not have you get there. But just so you've heard us say that there are several therapies for advanced liver cancer now. Next slide. So the whole theme of this morning is to not get to me, not get to the medical oncologist for advanced therapy because you've been prevented. So who should we look for and surveil and screen? Cirrhosis, non-cirrhotics with hepatitis B, and they may have any of the following characteristics. They're active hepatitis, family history of HCC, which can occur, our African-American population, Asian males over 40, Asian females over 50 tend to be a little bit higher in the risk group. And some of our societies even recommend surveillance in patients with chronic hep C and advanced fibrosis. Next slide. So what should we do? So in these two studies mentioned here, or study groups, fibrosis was sustained viral resistance response, SVR, should have surveillance every 6 months, and we'll come in another slide or two about what, so at least ultrasound. And the same theme here. Next slide. So what to do? We've been kind of conflicted and discussing in the organizations I am involved with about MRI, ultrasound. Well, MRIs are more expensive. They're a little trickier and very confining, claustrophobic. And so at least every 6 months, an ultrasound in this high-risk population we've just discussed, people hep B, hep C, especially with cirrhosis or fatty liver, you want to get an ultrasound every 6 months. If there's any confusion or not clear, you get an MRI. And going back to my training days, oh, gee, how hard could it be? Just check alpha-fetoprotein. Well, now we'd like to catch these earlier before the alpha-fetoprotein even rises. So it's not a bad idea to get that test, but you want to get these screening tests every 6 months, at least with ultrasound, before you get to a tumor which is putting out alpha-fetoprotein. And here's a picture just to put it in your mind of what things look like. Again, the CAT scan, feet sticking out at you, head on the other side. This is the patient's right, the patient's left. This is live TV, and I'm getting called by no caller ID. Probably selling me a credit card. All right, so in the liver, oh, sorry, back there if you would. In the liver, here's a spot, and that's a liver cancer. And over here, open, we're now in the surgical bed. The liver is in the background here, and that's this thing that you just saw sticking out and would be resected by the surgeon. Next slide. So again, to prevent, as Dr. Mauser said early on, and Dr. Poggio also confirmed, we want to try and prevent a lot of this. And so certainly our patients early on, we want to prevent and vaccinate for hep B. In the appropriate age, phenotype demographic, we want to try and vaccinate for HPV. Watch out for these viruses. We're going to try and catch them, prevent them. High resolution anoscopy in appropriate patients, colonoscopy, and of course the ultrasound I just mentioned. Next slide. All right, let's move on to oral. So here's our case, 58 years old, MSM, viral suppressed. There's his antiretroviral regimen. He's actually swished. He's got a relatively good CD4 undetectable viral load. He's immune with antibodies against these two hep viruses. Hypertension, smoker, not good, alcohol, a common theme in our oral head and neck cancers. Lesion in the tongue is seen, been painless for a year, and he has penile warts. And again, this is all suggesting there's some viral infection going on. What should we be concerned about? What risk factors? So here's the tongue, and you see this white patch right here, and that's abnormal. Next slide. So this is head and neck cancer. It's slightly increased in our HIV patients, and very highly associated. This demographic group is tobacco and alcohol use, often heavy. And we're not entirely sure what's the problem. Is it that's the toxin, or people who use heavy use of alcohol and tobacco don't tend to eat very well, and their diet's not very good. So a combination of things. HPV in our non or HIV infected patients is responsible for a significant proportion of these patients. Curiously, the HPVs do a little better. Those who are positive. Again, we'd like to have a strategy of preventing people from having HPV. Then on down here, early treatment, finding it, hopefully you're in a surgical or radiation stage. As you get more advanced, you may be surgical, radiation, and chemotherapy stage. Our HIV patients tend to do a little worse when compared to the non-HIV population. Next slide. Okay, we're leaving that area going on to skin. So here we have a 48-year-old female, on and off antiretroviral therapy. Here's her antiretroviral regimen. She's got a 350 count, undetectable, Hep B antibodies, occasional smoker drinker, unremarkable medical history. She thinks her mom, we threw that in there just to tease us, had a skin tag removed in her mid-40s because it could tend to run the family, especially in non-sun areas, it might run the family. Next slide. And this is a great slide Dr. Mounzer provided. We're going to say, look at this lesion and look at on the left-hand side, ABCD. So asymmetric, this lesion is serpiginous, is often said like snake-like borders. It snakes around, it's not perfect. The borders are irregular. Its color has black and white and brown, so very different color variation. Its diameter is large. I was taught anything larger than the eraser in a number 2 pencil is too large. And it evolves, it's growing over time. Next slide. So that is what a melanoma looks like. And our HIV patients have a higher incidence of cutaneous skin cancers. Could be the basal cell, the squamous cell, melanoma, Merkel cell, this very strange thing called Merkel cell. I just saw a case last week. So it is a little bit more common. If you've all heard of small cell lung cancer, which is the more aggressive type, it can occur in the skin where it gets the name Merkel cell and really has to be aggressively removed. Our HIV patients get the HPV-associated genital infections, and these can be associated with squamous cells of the skin. In this next bullet, you see that they're younger, multiple tumors, non-sun exposed areas. So we think sun is a problem, of course, for skin cancers, but our patients may get in the non-sun exposed. So we always recommend that either in the primary care office or dermatology office, you are stripped once a year and checked for lesions, especially if there's a history in you or family history. And the next bullet, melanomas in HIV patients, they can be worse and metastasize sooner. Basal cell patients treated comparably. The Mohs technique is very nice outpatient thing, and a little bigger excision, sometimes a plastic surgeon, if you're a squamous cell cancer. Next slide. I think we've mentioned here increased incidence of cutaneous cancers, Kaposi's. Of course, we're thinking non-ADMs today, but Kaposi's is a skin cancer in our more immunosuppressed patients as well as the others we just mentioned. A lot of this is associated with the HPV virus, higher infection rates with lower CD4, common theme, and melanomas, we've mentioned, as is a common theme this morning, may have a worse prognosis in our HIV infections. Next slide. I threw this one slide in because of Hodgkin's. Curiously, I just saw a new Hodgkin's patient last week who actually was infected from the age of 3. Of course, turned out, she's 25 now, turned out she had this from maternal fetal transmission, which is rare these days thanks to aggressive catch of the mom who's HIV positive. And so it's EBV related, we think. This is a study a few years back, you see 2003, out of a Swiss cohort where there's a little trend up in our Hodgkin's lymphoma, as mentioned by Dr. Mounzer. There was some concern, one report, again, it's about 10 years old now, that the NNRTIs had a higher rate, hazard ratio risk of having the Hodgkin's lymphoma than not. This has not been confirmed, but keep an eye out for patients with lymph node swellings. And the lymphomas, Hodgkin's and non-Hodgkin's, don't read the textbook. They can present earlobe, gallbladder, buttocks, sometimes lymph nodes second, and non-lymph node places first. Next slide. So my last slide before passing back to Dr. Mounzer to bring us on home, I wanted to leave you with this theme, which was actually mentioned early on. It's a really interesting point, immunosuppression versus infection. So bullet 1, are the HIV patients at increased risk of cancer? Yes, that's our theme today. But does highly active antiretroviral therapy decrease the patient's cancer risk? Well, you see yes and no. The yes is if your CD4 helper lymphocytes, your immune system is back online, your chance of Kaposi's and lymphoma goes way down, almost immediately. There's some studies to show how fast it goes back down, not to normal, but to approach normal. But no, taking your antiretroviral therapy is good, and you'll live longer and hopefully forever if we watch and catch these cancers early and metabolics early. But still with the HPV, EBV, hepatitis viruses, you get the cancers that we've all been talking about this morning. So that's where we have to be very much on guard going forward. So I will pass back to Dr. Mounzer.
Thank you, Dave, for this wonderful review, and you've done terrific time-wise. So to conclude, what I hope we were able to show you today, that most cancers develop as a result of exposure to modifiable risk factors, i.e. A good chunk of cancers are preventable. And these are really the measures that we have to help our patient really embrace in their day-to-day lives. Avoid smoking, extremely important. I think probably the #1 killer across the board is smoking. Vaccination, and proper vaccination and timely vaccination. The timing is critical. You don't want to vaccinate people too late after they are exposed to hepatitis B or after they're exposed to human papillomavirus. So very early vaccination and completion of the vaccination cycle is very important, and catch up. So sometimes you start the vaccination process, but you're not completing it. So catching up is very, very important. Skin protection, sun exposure is not healthy, especially people living with HIV who have a fair skin and a family history. Minimizing alcohol intake rather than avoiding it altogether, but ideally avoiding it would be better. Keeping a healthy weight. Obesity has been associated with many comorbidities, including a higher incidence of cancers. And that's also very important. Healthy diet, as Dr. Poggio alluded to, grains, fruit, vegetables, cutting down on red meat as much as possible, and so forth. I mean, these are, very known things, harder to adhere to. And obviously decreasing exposure to environmental carcinogens. And those are occupational exposure that people need to be aware of, and they need to really minimize their exposure to. So also what we learned today, and hopefully we were able to show you, that most cancers have a detectable preclinical phase, which allows us to really screen effectively and detect them early on so we can intervene and prevent them from developing or progressing into late stage disseminated cancers that are hard to eradicate and cure. And that's exactly, these are the different screening tools that we have available to us to really intervene early on. These screening tools can save lives. And as Dr. Poggio alluded to, that for colorectal cancers, colonoscopy, flex sigmoidoscopy, a combination of DNA testing / FIT testing, which is the Cologuard, these are important interventions. They are not that aggressive, but they can save lives. For lung cancer, people at risks, low-dose chest tomography is very important. For anal cancer, the pap smear and the high-resolution endoscopy. For liver cancer, imaging study, an accessible one being right upper quadrant ultrasound every 6 months. Extremely important to perform skin inspection in our clinics at least once a month. Systematic, where patients will gown, and then we go through systematically head to toe. Lymph node palpation, looking and screening for Hodgkin lymphoma, which as you saw, is a very prevalent cancer in people living with HIV. And it can happen at any CD4, more so when you have a lower CD4, but can happen at any CD4 count. And oropharyngeal inspection is very important, looking for oral lesions that are precancerous. The reason I'm mentioning all of this is because it's very important for these screening tools to basically be on the radar screen of both the clinicians and the patients. And I urge our patients to ask their clinicians at least once a year, what are you doing for me to prevent and screen for non-AIDS cancers? This is very important to really bring it up on the radar screen and to think about it. And to conclude, this is data from the WHO. As I mentioned very early on, they estimate that 40% of all cancer death can be prevented. And they can be prevented, obviously, by implementing preventive measures, and they can be prevented by screening on time and intervening to prevent those things from progressing downstream. And with that, I think we're gonna conclude our webinar, and we wanna thank you again for taking the time to listening to us today, and we're gonna open it for Q&A. So thank you very much.
Wonderful. Thank you, Dr. Mounzer. Dr. Henry and Dr. Poggio. This was tremendous, and this is, I feel like, a much overlooked topic regarding HIV and its intersecting issues. So I want the audience to kind of put on their thinking caps and think about questions that they may have for our presenters. In the meantime, while folks get warmed up, I actually have a few questions of myself just to kind of get things going. I really appreciated, Dr. Mounzer, that you said, ask your doctor, what are you doing for me? I think that's vitally important. And from a kind of patient self-advocacy perspective, and this question is open up to all the panelists, what advice would you give to patients who may be nervous talking to their doctor about some of the things that you've touched upon, talking about, you know, things they may be concerned about their body, you know, talking about or asking the question of their doctor, something's off. Can we talk about cancer? What advice would you give to patients who may be nervous about having those conversations and may not have the language to have those conversations with their doctors?
Well, I think I would answer and say, bring this up. Of course, who isn't nervous, who isn't anxious? Often when you come with some of these COVID era days, at our clinic at the moment, we're only allowing one person in at a time. Although one patient came in with someone else, he said, I've got him in because he's my translator. I said, well, you said that in English. How did you get past the front door? That's a cute trick. But if once you come in with yourself, with someone else, say, you know, I'm worried about cancer. Is that true in HIV? I think just put it out there and let the caregiver then comment. Hopefully you caregivers on the line this morning will take some of this to heart and look for these areas, especially for screening and surveillance and preventing. But I think it's a discussion that we just have to get past our anxiety and our nervousness and ask our caregiver.
Yeah, and I would like to add to what Dr. Henry just said. When patient comes to see their primary care for a routine follow-up visit, it's extremely important that that visits at least once a year entail what we call a health maintenance component of the visit. So health maintenance is very important. You know, we have to systematically, as clinician, go through a systematic list of what's happening with vaccines. Are you up to date with your vaccine? That's very important. Are you up to date with your screening test for cancer, for lipids, cholesterol-wise? Are we addressing risk factors like smoking? So health maintenance is a section. It's really an integral component of any wellness visit that must take place, and patients need to be aware. So this is clearly to raise awareness among our patient that when you go to see your doc and you're doing well and your numbers are great, that's not the visit. Like, yes, you don't have any complaints. You have no events that had taken place from the last visit until the present visit. You feel great. You're taking your meds. This is all good, but it's not enough. There should be a component of that visit that covers health maintenance. And under health maintenance, cancer screening really should come up. And this is really important for our patient to realize, well, listen, the most common cancers that are killing people living with HIV that are non-AIDS related, as we have mentioned, which are more prevalent than AIDS related, are lung, colon, anal to a degree. They are very morbid, not necessarily killing patients, but they're very morbid. And obviously liver in certain instances, you have lymphomas in other instances, oropharyngeal, skin, but really the killers are colon and lung and liver. So these are the ones that patients should be aware of and may want to bring up to the attention of their provider.
Very well said.
I would like to say that we understand if there is anxiety, fears to ask questions, but in a good physician-patient relationship, you know, we will listen to you. And the best way is to open up yourself to the physician and tell them, look, I'm nervous, I have these questions, do you mind helping me? And I believe most of the physicians will be very receptive to that approach and help you. And if not, then you should consider that relationship. But I think we're here to help you, to listen to you, and be there for you as physicians and try to answer the most questions we can. Help the patient like this.
And what also helps I think, is when the patient sets a list or at least thinks what he or she wants to ask before the visit. We really appreciate that when we go through everything. And just as Dr. Mounds and Dr. Poggio said, this needs to be a preventive visit. You're great, you're doing well, but what can we prevent? So think about that question and also develop your questions before you go.
That's wonderful. Thank you. I like what you said, Dr. Poggio, about it being a relationship. That's important. And also, what's the saying? An ounce of prevention? I forget how the rest goes.
Pound of cure.
Pound of a pound of cure.
Exactly. So thank you. So it looks like we have a number of questions, which is wonderful. Does HPV predispose patients to all cancers?
Yeah, I think I'd say yes.
So HPV is predisposes patients to really, obviously, cancer that emerges from the epithelium, which from epithelial cells, i.e., anal, cervical, oropharyngeal, skin in the genital area, perioral area as well. I don't believe that it increased the risk of lung cancer, for example, or liver cancer.
Correct. That's a great answer. HPV, we found it in epithelial regions of the body, and like Dr. Manser was saying, it is associated with cancers, as Dr. Henry was saying, also of the head and neck, genital areas, anal area. But mostly epithelial areas, but not like in other, as far as I know, in like colon cancer or liver cancer, as far as I know. So yeah, that makes sense. That's a good answer.
Thank you for that. What data is available regarding cancer vaccines for people living with HIV and the general population? I guess, like, is there different data sets?
Yeah, there has been a couple of studies really randomizing patient to HPV vaccination versus not. And what they showed is that patients who were vaccinated for HPV at the right timing, i.e. who are not exposed to HPV virus, who have already been exposed, vaccination was associated with a lower rate of downstream infection with HPV viruses, primarily the HPV strain in the vaccine itself, which are 6, at the time these studies were performed, it was the 4-valent vaccine, 6, 11, 16, and 18. 16 and 18 are the most notorious one. As Dr. Poggio alluded to, HPV 16 is associated with 90% of anal cancer, 70% of vaginal, cervical cancer. So when you vaccinate patient, you decrease their chances substantially from becoming infected with these viruses. And if they don't become infected with these viruses, you are clearly undermining their risks of developing cancers downstream that are driven by these infections. So there's also data to show that the incidence of AIN, atypical anal intraepithelial neoplasia, grade 3, which is kind of advanced, is significantly lowered in people who are vaccinated than people who are not vaccinated with HPV virus. So there's no question that HPV vaccination protects against the emergence of lesions which lead to cancers down the road. And that's why we highly recommend vaccinating people before they become infected with HPV, i.e. age 9 to 26, rather than waiting until they are highly sexually active and then they're infected. Because once you're infected with HPV, the chances of eradicating this infection after vaccinating the patient is very slim to none. Really, the vaccine is not very helpful in people who are already infected with HPV 16 or 18 for that matter.
Thank you. Thank you. Another question we have, is vaccination recommended for everyone older than 26? Kind of what are the recommendation and guidelines for folks over 26 years old?
Yeah, so let me say that folks above age 26, if we were to vaccinate them, which there is nothing wrong with, and we need to really risk stratify, and it's a shared decision-making process. But people need to be aware that insurance company, third-party payers will not cover for HPV vaccine if you are above age 26, because it does not fulfill the ACIP recommendations. So they will not pay for the vaccine. And remember, this is a 3 injections cycle, 0, 2, and 6 months. So, so the question is, what is the decision-making process that we go through with our patient? Again, it's a partnership to decide whether or not we should vaccinate. If we think that there is a good chance that, you know, our patient have not yet been exposed to all 9 strains in the vaccine, because right now we're using the 9-valent vaccine. There are 9 different strains. It is very likely that the patient has been exposed to 1 or 2 or 3 of these strains, but not all 9 of these strains. So vaccinating can still carry a beneficial effect. But right now, these are ongoing studies. The data is not clear in that regard. And we have to really operate on a case-by-case basis, as long as the patient is aware of the fact that they may have to pay for the vaccine. And then deciding whether or not the vaccine may be useful. If the patient already has very advanced dysplasia with HPV 16 documented on reflex testing, the vaccination may have little to really to play in this case, and may not really make a difference. But we have to discuss on a case-by-case basis. I personally, in high-risk patients, I am more leaning towards offering it if they are willing to purchase the vaccine than not.
Wonderful.
Yeah, I agree with Dr. Manser. I think that what we are trying to say is that there is not enough scientific literature or studies to report the exact benefits of vaccination after the age of 26. Being said, because we don't know whether that patient has been exposed to all the strains, different strains, the carcinogenic strains, I am in favor of discussing that with the patient and probably encouraging them the vaccination. But being said, there is the problem or the barrier of insurance and payment that unfortunately will be part of that discussion. So good points to remember, yeah.
Maybe a reference might mention, I'm listening as Dr. Mounds and Pojo answer that question. There's a cancer study group out of the NIH called AMC, AIDS Malignancy Consortium. If you Google AMC space HIV, you'll get that site, AMC space HIV, and shows in cancer, and for example, giving HPV vaccine to those HIV infected already didn't work out if they'd already been exposed to HPV. And so you'll see some of the data in the studies, but it's a nice reference to kind of add to those you've seen this morning as well.
Wonderful. Thank you for that. And we here at the Community Health Training Alliance are big advocates of searching for and finding peer-reviewed, supported, reputable medical sources. So as a follow-up to the audience, we will make sure to, if you haven't already done so, send that link out to you all as well. So, and follow up with any other resources. So another question, alcohol use, daily, weekly, occasionally. What amount seems to show an increase in cancer? Some say no alcohol is best. It feels like there are mixed messages. What are your opinions?
Well, that's I'll fall on my sword for that one. That's a really tough one. It's very, I wouldn't say controversial, but very varied, as the questioner suggests by the question. There is a fair amount of data that a little bit of red wine, for example, on a regular basis is health promoting. But of course, then sometimes patients get too much of any source of alcohol like wine. So we're not really clear what's too much, except we know it when we see it, so to speak. But, and hard alcohol is probably not very health provoking. Something about the riboflavins in wine, in particular red wine. So I would say if you have hepatitis, then probably it's no alcohol. But if you want to try and promote health and you're otherwise healthy, a small amount, in particular red wine, is potentially healthy.
Yeah, I mean, this is a tough one. Alcohol, again, it's a spectrum. the more you drink, the worse things are. Kind of as a guidance, when you look at Clinical Up to Date, when they discuss alcohol consumption, they discuss it in terms of 1 glass a day for women, 2 glasses max per day for men. I mean, again, avoiding altogether is the best, but this is not who we are. And sometimes, remember, we operate on the basis of harm reduction as opposed to, abolish completely alcohol from your life, which I can make a case that a little bit of alcohol in certain instances have a lot of favorable and, impact in terms of relaxing certain people, calming their anxiety, and so forth, and helping boost up their HDL. But again, I think the idea is to be conscious about the amount you're consuming, and you don't want to do that regularly every day. I mean, occasional consumption is not unreasonable as long as it's done with moderation. And obviously, the underlying host is also important. Older folks may not be able to metabolize and process alcohol like younger folks. So you want to make sure you put it in the right context. People with liver problems to start with, chronic liver disease from hepatitis C or B, a little bit of alcohol can tip them over the edge compared to somebody who has a completely healthy liver and was able to clear no problem. So using common sense is very important, but alcohol consumption is, in general, if it's regular and, not moderate, can be notorious. And there has been a nice paper in JAMA showing that life expectancy is limited among people who consumes alcohol compared to those who do not.
Yes, I agree with those comments. I mean, from the literature, there is evidence that suggests in these public health studies that moderate to in severe alcohol intake per day increases the risk for several cancers, including colon in men and women, or breast cancer in women. Being said, the big question is, what's the dose? What can you take every day? Is 1 to 2 glasses? Dr. Maunzer mentioned some of the recommendations for women and men that is different. And at the end of the day, I think everything is, I believe in moderation, common sense, like Dr. Maunzer was saying. Binge drinking is not good. If you are drinking alcohol for anxiety or because you have a lot of worries, sometimes that's not the answer. I think drinking alcohol alone is probably not it's just a worrisome thing, socially with friends and colleagues, but everything in moderation at the end of the day. And if you start feeling that you need to drink alcohol every day because, it makes you feel better, then I think you should consider that that's probably is not the answer or the best way to go.
Yeah. Yeah, I mean, let's put it this way. If I have to choose between a sweetened beverage and a glass of wine, I'll pick the latter.
I agree.
Thank you for that. I appreciate all the answers from all of you. I also want to lift up how great it is we talk about harm reduction, meeting people where they are, and discussing things on a case-by-case basis with each person. That's tremendous. Thank you. We have another interesting question. Does a patient who has recovered from HBV infection years before an HIV diagnosis have a higher risk of liver cancer?
So the question sounds like we had Hep B and we've recovered.
Yes.
So of course we've had that, and now we're HIV positive. That's a gray area, but I would say that's where we worry even without. Well, there might be cirrhosis or not. So I'd be a little concerned and would follow that patient. The ultrasound every 6 months might be a little overkill, but certainly easy and cheap, and maybe overkill surveillance might be a good idea.
Yeah, I mean, I agree with Dave wholeheartedly. This is a very, very gray area, but if you want to look at Hep B, it's a spectrum. On one end of the spectrum, you have chronic active hepatitis B. These are individuals with literally very high Hep B viral load. There is significant inflammation in the liver as reflected by their transaminase, AST, ALT. When you biopsy the liver of these patients, which you don't need to, but you see a lot of inflammation. So this is on one end of the spectrum. And then you have those individuals really with lower viral load, relatively normal inflammatory marker, AST, ALT. And then you have those who really have undetectable viral load and practically normal AST, ALT. And then you have on the other end of the spectrum, folks who literally, as the question alluded to, they were able to get rid of their hepatitis B. So now they have surface antibodies, they have completely normal enzymes, and they have absolutely no virus. Now, the risk of cancer is much higher, as you can imagine, on the left end of the spectrum, those who are very active, high viral load, high inflammation, and the risk is practically negligible. But I would say it's not zero, but clearly those people on the other end of the spectrum, on the right-hand side of the spectrum, meaning surface antibodies, meaning they develop natural immunity, undetectable viral load, normal enzymes, those patients are at slightly higher risk than people who have never been exposed to Hep B, but not enough risk to justify any monitoring or any screening per se. So we don't really worry about them much.
Mm-hmm.
Thank you. Thank you for that. I have a question. So we talked about prevention, and we talked about just kind of the areas where the risk of cancer can be reduced, smoking, things like that. There has been a real push and a real effort in recent years to stop folks from smoking, stop folks from engaging in those activities that can increase risks of cancer. Have you seen success in many of the number of prevention campaigns? And what are areas of prevention that you think there can be a campaign for, or there can be better work being done?
Boy, that's a really good question, really tough. We wrestle with this all the time. If it had been easy, of course, we'd have done it by now. And so it's not. It's a mental and a physical addiction, physically, mentally. And so it takes a village. So you have to have your support system, your significant others, family, friends, your doctor, your doctor's perhaps associate caregivers, psychologists, and everyone help you work through it. And then we have some medications that can help, the patches, the drugs, and the psychosocial. So, and that's a big investment, and not every clinic has that, not every patient can afford that. So that's a very good question, and I think a very long answer depending on the patient's alone and addicted and out of work and out of money, as opposed to someone who has a very good support village, both caregivers and family, where it's much more successful.
Yeah, I completely agree with this. It's an addictive behavior that requires a multifaceted approach. Several components have to kind of like get together in order to really fully support and help our patient to control that behavior and eventually contain it and practically suppress it at some point. With that said, I want to reiterate something important that Dr. Henry alluded to, but I want to repeat it, which is people who are heavy smokers defined as more than 30 pack year of smoking. Let's say they stop smoking, they are above age 55 and they stopped 3 years ago. They are still considered at risk, and they are still considered as an individual that can benefit from screening using the low dose chest tomography. So heavy smokers who discontinued smoking within 15 years from the day of their visit continue to qualify for screening. So the fact that you stop smoking today and you present it to your primary care 2 years later does not preclude you from being screened for lung cancer, assuming you are above 55 and you are a heavy smoker, and within 15 years from presenting to your PCP for screening.
Tremendous. Thank you. Thank you for that. And that actually leads me to our next audience question. We talk a lot about smoking and drinking and cancer. Is there a correlation between chronic drug use and cancer?
Yeah, I mean, the only probably, I would say, interaction between the two, or the interplay, is that people who are using drugs, especially if you are using needles, there is a chance of acquiring viral infections that can be oncogenic, i.e. HPV, hepatitis B. You can acquire hepatitis C, and if left untreated, it can evolve into, stage 3 or 4 fibroses, which in itself puts you at risk. You can, again, if you're not HIV infected, you can become infected with HIV, which, as I mentioned to you, HIV itself is an oncogenic virus. We know now that people living with HIV, even if they are suppressed, it depends on where this virus is integrated inside their cells, where it's embedded in their nucleic material. It can literally downregulate certain tumor suppressor genes, increasing the chance of tumor to emerge. And it can upregulate certain proto-oncogenes, which really are genes that kind of like stimulate viral replication and kind of like dim down the, the death, the programmed death of the cell, apoptosis. So HIV can in itself be notorious, and that can be acquired through drug use. Again, we're talking about needles.
Yeah, I think those are good points, Dr. Manser. It's very difficult for me to find a direct association between a specific drug for IV drug abuse and a cancer. However, as Dr. Manser was saying, all the behaviors associated with addiction, like adding tobacco smoking, drinking heavily, type of chemicals in those drugs that that the patient can inject, that have carcinogens, all those associated behaviors to the drug use have an important impact on the development of infectious diseases like hepatitis, some type of hepatitis C or B, like Dr. Manser was saying, or all those carcinogens that are associated with injecting some drugs into your bloodstream. So I think those are the points to build here. But again, a study associated a specific drug with a specific cancer, that's more difficult to find in the literature.
Mm-hmm. Thank you. Thank you for that. So we talked about the intersection of HIV and cancer among adults. What would you say for folks who acquire HIV prenatally? What are the screening recommendations for folks who were born with HIV?
Well, that's a good question. I don't know the answer to that. In my career as a hematologist oncologist adult, children, and we by default or definition claim 16 and under, are very different people and get things very differently. Their immune systems are different. Of course, their health is different. As I mentioned in my remarks, I diagnosed just this month a patient with Hodgkin's who's HIV positive at age 3 because she had a transmission and before we stopped preventing it. So I suspect the answer is that there is an increased risk because there's going to be, I don't know how much. I doubt it's the size of what we're seeing in adults, just by talking to my pediatric colleagues, but I'm really not sure of that answer, except that I think it's increased.
Yeah, I mean, I would say probably the most important risk factor for cancer genesis is smoking, and the second important one is aging. Age is very important, and our young adults and our neonatal infected kids, obviously what plays for them is the fact that they are extremely young, and that's really very healthy. We're not aware of any guidance in terms of screening for any kind of cancer in this age bracket, but we always should be on the lookout for lymphoma, for example, in anybody who comes in with a fever that comes and goes, or a lump in the neck or under their axilla. So I think we should definitely keep it on our radar screen, but the lung and the liver, I mean, again, mainly the lung and bowel are not prevalent among neonatally infected kids.
That might be a nice thing to mention. What Dr. Mounds just reminded me, this patient of this month with the Hodgkin's had the Pell-Epstein fever. And for our listeners and our care providers, that's a few days of fever, a few days not, a few days of fever, a few days not. That's a real tip-off. That's weird. And that should be brought to the attention of your caregiver.
Thank you. Thank you for that. Thank you for all those responses and all the questions from our audience. So it looks like we're just about coming up on time. I wanted to open up the floor to each of the presenters to kind of provide closing thoughts and just sort of what you would like to impart upon the audience today.
Yeah, I'm gonna, go first and say that our patients should be empowered to really discuss without any hesitance what can be done in terms of screening and prevention when it comes to these common non-AIDS cancers. I think it's very important, and the same enthusiasm that they have to really prevent, let's say, or reduce the risk of having a cardiovascular event. The number cause of death, the number 2 cause of death are cancers, so they should be equally enthusiastic and invested in embracing the preventive measures that can reduce the risk of these things from happening, but more importantly, they should be very proactive in discussing with their provider what can be done to screen and prevent me from coming down with these cancers. So I think that's really the main goal of our webinar today, and I bet Dave and Dr. Poggio share this with me.
Lucas, what do you think?
Yes, I mean, I second what Dr. Manser was saying. I don't think I have too much to add. At the end of the day, I think we have nowadays in the area of technology, there's a lot of information out there. We have to look at that, but be careful because some of the information is not right. And I think that this opens the opportunity for us patients or the patients to discuss this with their providers. And we welcome that. We welcome the discussion, we welcome the information. And I think that we have to be responsible for ourselves. At the end of the day, we have to be responsible for ourselves, be informed, and then don't be afraid to discuss it with the provider, who will probably answer to the best of their knowledge. And also, sometimes you have the opportunity to teach the provider. We are always welcoming new information and education, but again, it's important to have a relationship of trust with that provider. And if you don't feel like you have that trust, then probably you should, discuss that or probably feel comfortable with the right provider. But we are here for you, Dr. Manser, Dr. Henry, Kyle, all the community, all the providers that I know, they're there to help the patients. And the trust is very important. And always, if there's any questions or doubts, always be comfortable to bring it to the office and to address that so you feel comfortable with your care and, and your life.
And so as the senior presenter on the webinar today, I want to leave you with a very optimistic perspective. So I started practicing out of training and started being attending just as HIV came out. We know what was going on. We didn't know what it was at first. And then we knew what it was. And in the 80s, patients were dying. I lost usually 3 patients a month. It was terrible. And of course, now from HIV, that doesn't happen. So it's a wonderful era. I skip to work every day, taking care of patients whom I think we make a huge difference. My colleagues, especially Drs. Mounser, Poggio, and Kyle with information education. So it's a wonderful era. So now HIV, we have under control. The cancers, I think we also can have under control. And you've heard wonderful thoughts today, I think, on information, which is knowledge is power, on how to prevent, let alone treat. So I think we leave you with great optimism. Webinars like this, I think, do a great job at getting the word out. So I understand we're being recorded. So tell everyone you know about this webinar so they can listen in and gain the same optimism that we have.
Wonderful. Dr. Mounzer, Dr. Henry, and Dr. Poggio, thank you today for bringing us invaluable knowledge. And thank you, audience members, for being wonderful question askers. And I just wanted to remind everyone that at the conclusion of this webinar, there is going to be a survey. You're going to be prompted to take that. Just let us know how we're doing. Let us know how this conference is going. We'd love to hear from you. And to the presenters and to the audience members, thank you for being with us today. I hope you have a good week. Be kind to yourselves and be kind to each other. Have a good day.